Welcome to Medicine, Motherhood, and Missions, the podcast where real life meets big dreams. I'm Johanna, your host, and every episode will dive into inspiring stories from PAs, doctors, and professionals who are also dreamers and mission-driven changemakers. From the hospital halls to the hearts of our homes, and even into communities across the world, we'll laugh, learn, and uncover the challenges, triumphs, and everything in between as we see life through each other's perspectives. Looking for more joy and balance in your career? Don't miss our free guide, How to Be a Fulfilled Profession, your quick boost of encouragement with tips to help you thrive while juggling all your hats you wear. And if you've got little dreamers at home, check out Little Evie's Big Dreams on Amazon. These stories are meant to spark imagination, courage, and kindness, perfect for bedtime or anytime. Follow along as Evie, a little Sri Lankan girl, brings joy and creativity to her community while daring to dream big. This podcast is also brought to you with love by the Ephraim Foundation International, because empowering children and families in rural Sri Lanka isn't just charity, it's continuing a legacy of hope and creating futures full of possibility. So grab your cup of coffee or tea, settle in, and get ready for uplifting conversations that will leave you inspired and equipped to make a greater impact. Let's jump in. Welcome back to Medicine, Motherhood, and Missions podcast. Today's conversation is one that is deeply honest, powerful, and incredibly needed. So many women have been taught that suffering silently is strength, that enduring pain without complaint is maturity, that resilience means continuing to function while physically, emotionally, or spiritually unraveling underneath the surface. But what happens when women are misdiagnosed, dismissed, or shamed instead of cared for? What happens when grief from miscarriage, infertility, reproductive trauma, or even teen pregnancy is met with judgment, apathy, or silence? And what does it cost women when they are expected to power through experiences that were never meant to be carried alone? Today's guest is Kayla Branstetter, an English instructor, TEDx speaker, published writer, and researcher whose work centers on women's health, narrative medicine, reproductive trauma, and the cultural expectations placed on women's bodies and resilience. Her forthcoming book, Don't Be an Athena, releasing July 20th, challenges the myth that women must silently endure pain in order to be considered strong. Through storytelling, research, advocacy, and at times dark humor, Kayla explores reproductive health, medical gaslighting, infertility, miscarriage, suffering, and the urgent need for women to be heard and believed. This conversation is compassionate, thought-provoking, and validating for anyone who has ever felt unseen in their pain. So whether you're walking through grief, wrestling with unanswered questions, navigating healthcare experiences, or simply looking for a world where women are treated with more humanity and compassion, this episode is for you. So please welcome Kayla Branstetter. Thank you so much, Kayla, for joining me today on the podcast. I appreciate your time, and I look forward to this.
Yes, Thank you for having me. I'm excited.
Yes, I know. It's so interesting. I was just, looking up your information and listen to your TEDx talk. Tell us and our audience here a little bit about your story and why you decided to write this book, Don't Be an Athena.
So I need to go back to the beginning, because I am a daughter of a teen mom. My mom got pregnant with me in the late 80s in Southwest Missouri, where tradition dictates the culture, and that was a taboo topic. And I witnessed a lot of judgment from my mother, and in many ways we lived the stereotypical teen pregnancy life that many associate with the alarming statistics. We lived in poverty. I Medicaid, SNAP, WIC, and my mom was forced to get married because that's what tradition was saying. That's the right thing to do to keep me from being born out of wedlock. So she didn't have a lot of choices on getting married, but it was very evident that the marriage was not going to work out because they were essentially strangers when she discovered she was pregnant with me. They did divorce, and my mom did get into a relationship fairly quickly, got remarried, and my brother was born. And in that regard, she had her second child by the time she was 20. And my stepdad, we lived in domestic violence. It was, he was he was mostly physical toward my mother as far as the like physical abuse goes, but there was definitely emotional abuse, financial abuse. And it opened my eyes now that I'm older that in domestic situations, you don't leave them, you escape them. And there's a lot of strategy behind trying to leave such a violent relationship. But my mom was a high school dropout. She did achieve her GED. And when I was 4 years old, she graduated with her associate's degree at the same college I'm currently an instructor at. So I feel like that's a full circle moment. When she filed for divorce from my stepdad, she returned to college. And when I was in 8th grade, she graduated with her bachelor's degree in sociology and became a caseworker for 10 years. So I saw that resilience, that grit, that desire of survival, that this decision, like when she became a teen mom, it didn't define her. It was part of her story, but it didn't define her as a mom and as a person. And she was still able to be a successful person. But from that experience, I was adamant that I was going to follow the correct path that society had for me. So I graduated high school with honors. I attended college. Met my husband in college. We got married. I started my career, had the health insurance, and it was time to have a baby. And we suffered from unexplained infertility. That was very damaging to my mental health when they can't figure out a reason why you're not getting pregnant. It exposed me to people and how they approach women who struggle to get pregnant. And it was quite isolating. And I think people struggle, if they've never been through infertility, I think people sometimes struggle to know how to be compassionate and empathetic to couples who are suffering from infertility. I did eventually get pregnant without infertility drugs, but when I did get pregnant, there was an issue with my blood work that it alluded to maybe I was pregnant with multiples, but then my progesterone was a tad bit lower than where the doctor would like to be. So I had ultrasounds very early. And after my first ultrasound, another one was scheduled 2 days later. And essentially the doctor told me that if we didn't hear a heartbeat, if we didn't see growth, then I needed to weigh my options on what I wanted to do. Fortunately, we did hear a heartbeat. We saw growth, and then I was put on progesterone for my first trimester. But I felt I've been pregnant 3 times. I did not enjoy being pregnant all 3 times. I appreciated being pregnant, but I felt that joy of being pregnant and appreciating being pregnant was completely robbed because we tried so hard, and then the doctor told me I was going to lose her. So it just felt like it was a day by day of, okay, she's fine. I looked up the statistics of, okay, a 90% chance of survival if I go into labor at 28 weeks. And it just a lot of anxiety that I didn't get to enjoy being pregnant. And I had a miscarriage in my second pregnancy. I got pregnant pretty quick, like within a month of trying, which was a complete contrast with my first daughter. Something felt off. I didn't want to tell people I was pregnant. I couldn't put my finger on it, but I felt like I knew I was going to lose this child because it just felt different. And I had my miscarriage, and just like the infertility, I was exposed to another side of humanity. I think people just get awkward because they don't know how to respond to a miscarriage and a loss. Then my third pregnancy, which is my second daughter, I didn't have any issues getting pregnant. I didn't have issues as far as my hormones. I had terrible morning sickness all 9 months. But just like my first 2 pregnancies, I just could not relax with being pregnant. It was when the baby wasn't moving, I'm feeling like, okay, oh my goodness, what's happening? Is the baby okay? Just a lot of anxiety because when you're told you were going to lose a child, you did lose a child, and you have severe morning sickness. I just felt like pregnancy and the happiness that can come with pregnancy was completely robbed of me. And that just led to, I felt isolated. I did a lot of my own gaslighting. I was toxic to myself. And I don't want my daughters to go through that. And I don't want any other woman to go through that. And so that's inspired my book. So it's been about a 6-year process. It was about 2020 when I started planning this book.
Okay. Yeah. Wow. Okay. So there's a lot to unpack in what you just said, because
Yes,
there, a lot of really important topics, especially just talking about the teen pregnancy and the judgment that you saw for your own mom, and then domestic abuse, violence. Actually, my husband and I were just talking about this last night about how, they're kind of pushing for more people to have babies, increase the population, but the structure for women, the resources for women, for parenting, for, thriving right now are really not there, with paid
absolutely.
maternal leave or, expenses for daycare. I mean, it's like astronomical, the cost of having a baby, and just having the baby itself and, giving birth is the cost of that. First of all, is extreme. And then going into figuring out, and I work in the medical field. I'm a PA and I work with a lot of nurses. And I remember nurses coming and they're like, yeah, I had some of them were like, I had a hysterectomy and 2 weeks later, I'm back on the job. I had a
Mhm.
baby. I have like maybe 2.5 weeks, 3 weeks, and then I'm back and working, because
Yes,
they can't afford to take time off and they can't afford to, not pay for daycare because they need both incomes. And it's just a cycle, a cyclical cycle of just, constant paycheck by paycheck, if, if they're even able to do paycheck by paycheck. And so, so your story kind of touches on just a lot of that. That's the undercurrent of what we're dealing with across the country. And then even with, so what are your thoughts on that first? Then we can talk on.
I actually posted something on my social media not too long ago about this issue. I think it
Mhm,
was Katie Miller said something on
mhm,
her social media about the teen pregnancy rate dropping. I think it was 70% since the early 2000s. I'm as someone who has a parent who is a teen mom, and I've worked in education for
mhm,
16 years. 10 years I worked in a high school. Now I'm in higher education the last 6 years. And I witnessed there was little difference between my mom being pregnant in the 80s and a young woman being pregnant in the 2000s or 2010s, 2000. As far as
mhm.
like the community judgment, there were more resources as to women didn't feel, these teenage girls didn't feel like they had to drop out of high school. And I feel like high schools did a better job of accommodating. But teen pregnancy cost taxpayers so much money and
Mhm.
not only that, we don't provide enough resources for teen moms. And we obviously want them to be successful. When we are complaining about the birth rate declining, but we're failing to look at the cost of living, our healthcare policies, our parental leave policies. I'm not even going to say maternity
Mhm.
leave because I think it needs to be
Yeah.
parental. Like we need to include the
Eh,
fathers in the parental leave.
Yeah.
I'm a huge
Mhm.
advocate for giving
Yeah.
fathers an opportunity to stay home because I think postpartum depression would go down.
Yeah.
We want fathers to
Mhm.
step up and be fathers, but in order for that to happen, we need
Yeah.
to provide the opportunity for them to bond with their
Mhm.
children.
Yeah.
And when we're not ready to, I feel like what's going on in the country is we're gaslighting women into becoming mothers without providing them with the proper support to become mothers.
Right.
And if we're
Exactly.
wanting it, yes, and if we're wanting the population to increase, and if we're going to say we value families, then I think we need to actually pass policies that value families.
Yeah. Exactly. Yeah. I mean, 100%. That's what we're seeing right now. And hopefully we can see more policies that actually help families, because it's not enough right now. And then going into the other thing that you touched on was the domestic violence and the support system for women in those, because you said you don't run away from it, you escape it. Can you expound on that a little bit?
So some of the chapters in my book do touch on domestic violence, and I will go ahead and give the content warning. I wanted my book to be as raw and honest as possible. So certain chapters have extreme language, and that's on purpose because that is a true reflection of what these women had endured and the type of environment they were in. And I didn't really touch a lot on domestic violence. My mom is in the book, but it's mainly my story and not so much about the domestic violence that occurred later. But I have 2 to 3 women that encountered domestic violence, and these men, they isolate them. They do their best to make sure that it's all about control. So they isolate them from their friends, they isolate them from their family. They make them 100% dependent on this person. And so they must, when they find a dollar bill, they're stashing it and trying to find a way to it's difficult to raise the money to escape, because when you're trying to escape domestic violence, you obviously need to have the resources to do so. I'm in a rural area, and getting a woman into a halfway house or a women's shelter to where she can escape is quite difficult without trying to establish some form of a network. And that's what I mean. Like, sometimes these women can't leave for months because they're trying to get the money, they're trying to get the network to help them escape. And when they do escape, will the law be on their side? I mean, you can do a restraining order, but a restraining order is not going to do too much other than you have it documented that your life could be in danger. But there's one woman in my book her name's Stephanie, and proceed with caution with that book because it's quite violent. She had to escape. She befriended a local police officer who helped provide the proper protection. And as sad as it was, how she survived was her ex-husband finally moved on to another woman and left her alone. But then that other woman is now going through what she had gone through.
Yeah.
But she had to be strategic. She did get a job. Anytime that she had extra money, she would stash it in an envelope at her employer. She had 2 sons that she had to think about. She would reach out to some family members in a different state, and just you walk on eggshells and tiptoe around the person, all the while developing your escape plan.
Yeah. Yeah. It's interesting. Another pediatrician was just sharing a post on Instagram today. It was like, we normalize fear of sharks, even though maybe there's 34, I think, deaths per year from shark attacks or something like that. I can't remember the exact data, but we don't normalize fear of this type of kind of man. And there are so many more hundreds to thousands. Wish I could have remembered the statistic of how many women are, violently abused or, suffer at the hands of domestic violence annually, yet we're told for them to suffer silently, or that, their voice isn't heard as much. And there is and I think this is why you're writing this book, right? Because there is something still yet to be done for women. And how do we prevent this? How do we change the status quo for this to be more recognized, for how do we, raise our sons to be better men? What are we lacking here? What is happening that this is, still persisting? And why are we still struggling to not judge? And why are we struggling not to find these women's voices truthful and trustworthy and hear them from the very first time they say something?
I think with the woman I interview, Stephanie, in my book, she is the first to admit that she was judgmental toward women in domestic violent relationships. Because in her mind, prior to her experience, she's like, well, she can just leave. They're being over dramatic. And then she had gone through it herself. And that's when she realized I was in the wrong. But we shouldn't have to go through something to believe somebody. And I think we still have that stigma of, well, how bad is it? And again, we struggle to believe her where violence is occurring. I think it begins with, I feel, humanities of just teaching people different perspectives and how to have empathy and compassion and the power of storytelling and learning to listen to people's stories uninterrupted and believing them and looking for the signs. Sometimes with abuse, she may not come forward, but there may be subtle hints. And because communication is 90% nonverbal, and sometimes you need to really pay attention to be able to know what a person is going through, because oftentimes they're not going to come forward and say, hey, this happened, this is going on. And they need to build a trust with you if they are going to be honest about what is happening and in the privacy of their homes. I think it does start with education. I'm a big advocate of comprehensive sex education across the board. I don't feel like sex ed needs to be a state by state. I think we need to have very similar curriculum across the states. And I do feel a big component of sex education can be on relationships. And we do need to educate our sons. I think there's this dangerous idea of what being a man is that has occurred for centuries. Men don't cry. Men have this warrior mentality. But who established those traits? Society did. And if we're ready to evolve as humanity, I think we also need to create a society that allows boys and men to be honest with their feelings and knowing how to properly treat their partners. And I think that starts from, like you said, from boys and creating an environment that allows those type of conversations to happen.
Yeah. I mean, just going through, your experience working with high schoolers and teens. I mean, from your experience working from that, from the teen pregnancy aspect to this domestic violence aspect, what has been your perspective from seeing teens and their responses to, sex education and what they're being taught and, working with them on an everyday basis when you were in the high schools? What was your takeaway from what you think they're really learning, and how are they responding to things, and what is actually being lived out? Are they getting certain messages, I guess?
When I was teaching high school, and it could differ now, each high school is even different on how they approach sex education. But when I was teaching high school, they didn't really teach sex education. So what students were finding out about their bodies and about relationships were probably whatever their friends were telling them. If their parents were even having those type of conversations, probably whatever is on social media or the internet. And what's unfortunate about avoiding the conversation. And I remember when we had a new principal and he asked me, what changes do you feel like we need to see in the district? And I was candid. I told him, I said, we need to have a sex education class. He goes, do we not? And I told him, I'm like, to my knowledge, a lot of our students are not in a sex ed class. And I think he didn't take it as seriously, but as an English teacher, I teach narratives. Students would get candid about their experiences in narratives. So I could get to stories from these students that are completely different than maybe the principal. And so when something like that happened, I know women are being raped. There is teen pregnancy. It sounded like there was very little talk about sex education outside of there was a puberty talk when they were roughly 5th and 6th grade, getting them ready for, hey, you're going to have a period, or this is what's going to happen to the body. And the amount of sexual assault cases I have hotlined and these were the cases that I became aware of. These aren't the cases that went undetected.
Yeah.
And what was alarming was 2 cases I remember, they didn't even realize that they were raped. They didn't know, because I think that they feel like this violence associated with it, and it can, but in both cases, it was the same perpetrator, and he was manipulative, and they didn't realize manipulation is a form of rape. And I told them, like, did you say no? And they said, yes, we said no all the time, but we reluctantly agreed to get him to stop, or we only agreed to this. And when we did this, then he fully raped after we did not agree to that. And they didn't realize, like, legally, this is rape. And I've brought that up that our girls don't even know that they're being raped when such acts of violence happen. And after that, they don't know what to do afterwards. What are your legal rights? What does that process look like? And in the state of Missouri, there are no statute of limitation with rape. So if and when they're ready to file charges, they can whenever they want to, even into adulthood. One girl was going to file charges, but when she found out the process of filing charges, she decided she did not want to do that. And that's tough. I feel like we're not doing enough to protect our students. And even with boys, if we want to break the cycle of boys sexually harassing, and there are girls who sexually harass boys, I don't want to leave that out, but I think we need to have a conversation. What is sexual harassment? What is sexual assault? And everybody is clear about what those definitions are, and quit demonizing teenagers for having these feelings because they are teenagers and hormones are playing. And I think you need to be honest about these types of feelings instead of making them feel ashamed that they have these feelings or ignoring it altogether. Because when you ignore it altogether, at least in my area, you do have teen pregnancy. And then do you have the right support? And it depends on the teen mom, if the family is able to support her or not, or if they are going to accept the fact that she's a teen mom. And we need to do more of educating our teenagers about their bodies, about specific definitions, and just trust them, I feel like, to make the right decision. When you can empower them, then they can make the right decisions.
Yeah, those open lines of communication are so important. And it starts in the home too, like as parents, us talking to our kids and keeping that trust open too. Not everyone has that though, I understand, but those who do, I mean, it starts with us too as parents, right?
100%.
Yeah. And I mean, I think back, like I have a nonprofit in Sri Lanka and, one of the programs I work with, they have a program where they talk to kids from, 5 to 17, and based on the age appropriateness, they talk about like what is, appropriate, what is not appropriate. And they want to make sure that these kids know, what is wrong and what is right. And meaning who to watch out for, who to watch out for, and bad touch, and, people who are trying to, like what you're saying is, manipulate or take advantage and, from these little kids. And so, they're doing it there to help, these kids there prevent, emotional, sexual abuse, all of those things that they can come across. So why can't they do that here, right, in America? And, we have programs there where, women face domestic violence, but they don't understand it. They're not that, they may not realize it. So we have those educational programs to teach them what to look for and understand what they may be going through is not right. Education is what I'm saying is so important.
Yes.
As you said too,
yes. And
having them understand.
Yes, it was important to me to have honest conversations. I have a 6-year-old, and we have conversations about good touch, bad touch of when, and I leave it up to my daughters if they want to hug family members or not. So I don't sit here and try to force my children to hug a family member if they don't feel comfortable to hug them.
Right.
And because I want them to know I'm not comfortable with this. So I'm not going to just give everybody a hug, and I don't make them feel bad for not giving somebody a hug. I feel like that's 100% up to them. I have covered their anatomy with proper terms so they know what what that language is. And that comes from years of teaching in the K-12 district, because sometimes Sometimes teachers, especially if you have a new teacher, they may not understand that when a child is being groomed or sexually abused, the abuser is not using the correct terms. They're going to put child-friendly terms affiliated with it. So we've had students like my uncle's doing something to my flower, or they're doing something to my cookie, and come to find out that they nicknamed their bodies that to make it kid-friendly, but the child didn't know that that was an inappropriate touch or the proper anatomical terms for their bodies. So it's so important that my daughters know the proper names to their bodies and that there's always consent. So anytime that my daughters have a question about their body, I try to say, hey, is it okay if I look? Is it okay that we do this? So they know that consent is so important, even on something as if they have like a bug bite on their back. I'm like, okay, is it okay? Can I look? And they're like, yes, you can look. It's itchy right here. And so that way it does start from home, of teaching our children that it's okay to give consent and there's a good touch and a bad touch, and using proper anatomical terms. Because like I said, in my background, a lot of groomers will use child-friendly terms so they can execute what they want to, and that's not okay. My daughter knows that she's going to get a period. I didn't make it a big deal. But yeah, education.
Yeah. Yeah. And going back to kind of what this may all kind of stem from is, do you think that our culture still romanticizes female suffering? And like, why are women often praised most when they endure pain quietly?
I do think we romanticize pain, and I think we just view women are warriors to begin with. Women are resilient, and the amount of pain, whether it's physical, emotional, and not only that, what the average year for a woman to be diagnosed with endometriosis, what is it, 5 to 7 years to get like a diagnosis of endometriosis? And that's a painful condition. And there's not a medal to be won. And I don't know why we're treating women that like it, just treat your period pain with a Tylenol when you're in, you can't even go to work. And I think we do romanticize it. And sometimes I feel like women are just as guilty as society as a whole for like saying, hey, look what I can do. I can do this, this, and this. And I think it's okay to know what our limitations are and not be afraid to ask for help. But at the same time, when we ask for help, we can't be dismissing that help. So I know when I go to the doctor, it took a lot of courage for me to go to the doctor because I have been dismissed before. So when I've reached that limit of like, okay, I guess I will go to the doctor, I'm already going into the exam room with this preconceived notion that I'm not going to be heard. And I know so many women who have that exact same experience.
Yeah. And what does that like medical gaslighting mean to you?
To me, it's this diminishing, or when you're saying something about your pain and they redirect it. So when I had my second daughter, I asked, it wasn't that too traumatic of a labor and delivery. Very little injury, but there's still some injury and some pain affiliated with, especially after giving birth. All I requested was naproxen. Like that's all I requested was just basic naproxen. My regular OBGYN had to leave, and a male OBGYN came in with his rounds, and he asked me if I had any questions. And my question was, may I have some naproxen? And he said, no, you're fine. And
after you gave birth?
I just gave birth, and like he came in and like massaged my uterus like they do. So that was already painful. And I mean, I'm not asking for a controlled substance. I'm asking for prescription strength Advil. It's like what I am asking for.
Exactly.
And he refused to give it to me, basically made me feel like I wasn't in pain, that maybe he felt like I was over exaggerating my pain. And in that regard, I'm like, well, just give me my purse. I'll just give myself Advil.
Oh my goodness. Yeah. That's like just ridiculous. And I can't believe that, you had to go through that after having a baby. I mean, come on, it's just naproxen.
Yeah, I wasn't asking for morphine or an Oxycontin. I was asking for naproxen. And so And so many women go through that. I've
Mm-hmm.
interviewed women like with endometriosis in my book. And then I know it's no longer called PCOS. What is it called? PM? Is it?
Metabolic. Yeah. Yeah. It's a metabolic. Yeah. They changed it to include the
They just,
metabolic disorder because it's more of the full like metabolic dysfunction.
and, and I interviewed 3 or 4 women with that condition
Mm-hmm.
and having cyst burst and the type of pain they were in. And
Mm-hmm.
just, I feel they also encounter doctors who kind of diminished their pain and just made them feel like,
Mm-hmm.
wait a minute, am I not in as much pain as the doctor says? When the doctor refused to give me naproxen after giving birth, it just made me feel like, one, I was unheard. I wasn't even valued as a human body. Like, here I am saying I'm in somewhat of pain. And it was like,
Mm-hmm.
okay, well, suck it up. You just had a baby. It's time to be a mom. And I'm a big advocate for what's good for the baby is taking care of
Mm-hmm.
moms. And if we can
Mm-hmm.
create a better system of taking care of moms, both mind, body, and soul after having babies,
Mm-hmm.
then I think that's just
Yeah.
creating a much better situation for our children.
Yeah. Yeah. And yeah, that's something really important to talk about because I feel a lot of women feel like they're not heard really well. And I'm not sure how we can get better at that. So from your perspective, how can providers listen better or hear women's pains and, symptoms better?
I've been teaching this to my narrative medicine course. I'm teaching narrative medicine to high
Hmm.
school students for the first time, and we're having these
Hmm.
conversations about not so
Hmm.
much about women, just patients in general, but I feel many women will understand where I'm coming from.
Hmm.
When we go see our providers, I feel so much of
Hmm.
patients is reduced to what is on the screen in a checklist. It's, do you
Yeah.
have headaches? Do you have nausea? Do you have fatigue? And you're just like checking a box.
Hmm.
And we heard from 2 doctors this past week in my class, and one doctor said he feels like there are 2 patients. There's the eye patient, which is the patient that's on the screen, and then there's the actual patient.
Hmm.
And so often, I think doctors look at what's on the screen and the story that the screen is telling them in the medical chart, and not so much of the human that is attached to that checklist. And he said that he had a friend who had breast cancer, and she sought treatment at one of the country's top cancer institute. That they were up to date on the technology. They had like a self-playing piano, and she only went there for a couple of visits, and then she returned to more of a local doctor, an oncologist. And he asked why, and she said because the doctor that was more local touched her breast, and that was important to her. Because even though this cancer institute had the best technology and at like a molecular level and her blood work, they can keep track of her, it was important to her that a doctor went above and beyond to touch her breast to make sure that a lump was not there. That was important to her. So like that human connection is, I think, what's missing, because we do reduce patients so much to what is on the screen and to a checklist. You come in, you get your blood pressure, you get your temperature, you get your pulse, your oxygen, your weight, your height. And then the nurse asks you a plethora of questions and you're responding to them. Then the doctor comes in, looks at the screen, and that's that. Dr. Rita Sharon is an MD, and she's one of the founding members of narrative medicine. And she talks about how we reduce patients so much to a checklist. So she, instead of asking, do you have this, this, and this, and the symptoms, she takes time and says, what do you want me to know? And she opens that conversation up to the patient and let the patient talk. And I guess on average, doctors interrupt a patient within the first 14 seconds. And just don't assume a patient's symptoms, don't assume a patient's story. And I feel, and I'm not saying every doctor, there are great doctors out there. And I know with coding and the charting, it's an overwhelming, and narrative medicine is also about addressing physician burnout, but getting physicians and patient back to a human level and not just a checklist, if that makes any sense of.
That makes perfect sense. But yeah, because, in school, where I remember someone came in and was talking to us and saying, here's, we're teaching the symptoms to look out for every single diagnosis out there, and conglomeration of different symptoms that align with certain different diagnoses. But yet, each individual person is going to have something unique, and not everyone is going to present the same way. And so that kind of stuck with me, because, just thinking as you're saying, from that human connection, that human perspective, every single person is different. And so it's interesting because we were taught that, that even though we have the box of symptoms and, per each specific thing, everyone is going to have a little difference to them, and everyone's going to be a little unique, or respond differently and that, comes from the whole perspective of that human individual, their experiences, everything that they have gone through, their feelings and everything that they're going through right now from past to present. And so it's interesting. And I do know that there are probably, a lot of providers who struggle with that and maybe I'm playing the devil's advocate here because I know how it is from the provider's perspective, with insurance and, I heard just the other day, I think, or this morning on the news, I think a group of hospitalists in Seattle actually have formed a union because they are so fed up of the restrictions on patient care and the deliverables and everything that are put on physicians and providers and, PAs, nurse practitioners, everyone, and they want us to do so much.
Yes.
And, for one person to do probably 2 or 3 people's work, and that is a huge strain.
Absolutely.
But also the point of that human connection is important because no matter what, most people got into medicine for that, human connection of wanting to help someone. Because, no matter what, I think that's really what a lot of people want to do in medicine. And so,
yeah. And I think that's why people go into medicine. Not my daughter, my sister was a pre-med major and was a talented pre-med student in her undergrad, studied for the MCAT and decided she worked as an MA for a couple of years. And now she owns a coffee shop. And part of the reason why she had gone from medicine to businesswoman, and she goes, the system is corrupt. And she worked in an orthopedic center, and she knows that said patient needs surgery, but insurance wants said patient to do 6 months of physical therapy, but physical therapy they know isn't going to fix the actual issue. They need to do surgery. And she said it was just so disheartening to continue to fight with insurance companies and seeing the doctors. And that's probably a scene that I think a lot of patients don't see is you do have doctors who are advocating for their patients with insurance companies. And narrative medicine is just as much for the physicians as it is for patients. I talk a lot about the patient side, but like next week with my students in narrative medicine, they're future healthcare professionals, whether they're nurses or wanting to go to medical school. I'm going to talk about suffering and grief and trauma. And when, as a practitioner, you're encountering that's like secondhand trauma and it needs to go somewhere. And so we're going to talk about how to connect with your coworkers and with other people to how to write, how to cope when these tragedies occur in your career. So we did discuss a lot about patients this past week, but this week I'm going into the provider side of narrative medicine of how to take care of your mental health when the system is designed to work against you.
Yeah. Yeah. We can go on for hours on that too. But I do want to go back to your point of the patient side of things, and the importance of that human connection. And I feel it's so easy to feel that lack of connection when you're in there for like a 15-minute appointment and you're in and out. They talk about one symptom, one thing, and you have like 10 more things to talk about that they couldn't even cover. And you're still feeling like, now what? What's happening? Am I going to be okay? Will, this treat whatever I'm having? And, is there going to be a solution? And I think that's the difficulty, really, Because, how do you feel as a patient? If are you really feeling that you really got everything that you need in that 15 to 20-minute appointment,
Yeah. And
And that's a hard ask.
I think it's difficult, and I'm optimistic because I'm working on my doctorate now in narrative medicine. And
Mhm.
specifically, I'm getting a doctorate in healthcare education to build curriculum to address the art side of medicine and not just the science. And
Mhm.
part of my research is tied to AI, in that I'm hopeful that with AI, we can monopolize time better, and with AI actually
Mhm.
become more connected, because I'm hoping that AI can provide a helpful resource to providers so we can get back to that human connection and get back to like,
Yeah.
how do we prioritize and capitalize on a 15-minute office visit that's not so much as just checking boxes. Like, if AI is going to
Mhm.
help do that, then maybe we can get to the actual connecting part.
Yeah. Yeah. And it's the questions that we ask too, as you said earlier. And I know there's another PA I had on the podcast a while ago. She works with nutrition and pediatrics, and she's kind of changing the game in how to communicate with patients regarding nutrition and obesity, and helping providers better communicate with that instead of just be like, are you eating healthy? Are you
Yes. Are you
walking, 20
exercising?
minutes a day? And there's like so many other ways we can communicate with them on a different level where there can actually be change. And I think that's what you're getting at in this narrative medicine and the art of medicine, is that how do we change the way we talk and communicate with patients instead of just asking point blank, symptomology questions, but
Mhm.
rephrase those questions to get to the heart of how the emotion behind the symptom in a way sometimes,
Yes,
if that
especially
makes
with
sense.
nutrition and with weight. If somebody
Mhm.
who's obese is going to a nutritionist, they there's already a lot of shame attached to their
Mhm.
weight. There already is. And I
Mhm.
so many women I interviewed in my book with PCOS. Like I said, I know it's not
Mhm.
PCOS, but I can't think of the acronym
It's
right now. It's like PM.
polyendocrine metabolic ovarian syndrome.
Okay, it's going to be take a little bit.
PMOS.
They were so
PMOS, yes.
offended when a provider asked them, "Are you eating healthy and exercising?" And
Yeah.
they felt dismissed of, they're telling me to eat right and exercise. But with certain
Mhm.
conditions, like, what does that look like? And if you have someone who's overweight and is a single mom working 2 jobs and they're eating fast food,
Mhm.
well, what strategies do we have
Mhm.
to help ease that burden? Like, part of that food and being overweight
Exactly.
is probably attached to
Mhm.
mom is in survival mode, and she's just she's
Mhm.
putting herself last like a lot of moms do. And so asking her, like,
Mhm.
are you eating right? Do you have time to exercise? They're probably like, are you kidding me? And like you said, how do you
Yeah.
approach that of, okay, what do you want me to know? Like, as a doctor, if you're approaching somebody who's overweight, what do you want me to know? And just creating that safe space
Mhm.
so you can get to the actual root of how this person got to this
Mhm.
situation to begin with, without the shame
Yeah.
attached to it.
Mhm. Yeah. Or even like a diabetic who is non-compliant to their insulin, but maybe it's because they can't afford the insulin,
Or they're
and they're
rationing it.
just trying to rationing, exactly, rationing it out. And that's why their, A1C is still through the roof, but that judgment and apathy. So you talk a lot about judgment and apathy in your book too. And I just also wanted to touch on, like, why do women often feel pressure to prove their pain before they are believed?
I think that's a societal expectation of, and I think women will lie about their pain. If you ask a woman, like, what's your pain level, 1 to 10, they may say they're a 3 when actually they're probably a 9.
Mhm.
And it's just society, because I think women's bodies, in hindsight, I feel women's bodies have just been studied in science. If we think about, like, out of the thousands of years
Mhm.
of humanity, women's
Mhm.
bodies, and even with perimenopause and menopause, aren't we just now kind of studying
Mhm.
these symptoms? And
Mhm.
I think it's because we silence women's pain because we truly just don't understand a lot about the woman's body.
Mhm. Yeah, that's very true. And I think there's so many people who are talking about that now with, a lot of things are based on a certain, male. And this is why that diagnosis is there, but it's
Mhm.
not from, not only just women, but, different cultures or different ethnicities may have different types. Even like a rash on a skin may look different just based on because of the melanin content,
Mhm.
and that changes the appearance of the rash. And so, even simple things like that, we're only now communicating about and talking about and being educated on, and so it's very interesting.
And even culturally, I think it's important
Mhm.
for healthcare providers to you can't be aware of every culture, but being aware of some cultures. I interviewed a woman who is Korean American. She's first generation Korean American. Her parents
Mhm.
immigrated from South Korea, and so much of her reproductive pain was tied to her culture. In that
Mhm.
she had endometriosis, she had heavy periods from a young age, but there was this stigma that if you had gone to the gynecologist as a teenager, you're sexually active, and that would bring dishonor to your family, and so you sometimes just diminish this because it could be a defect, and if it's a defect, that can bring honor or dishonor to your family, and knowing how to have that conversation of respecting the culture, but still getting to the root of the symptom.
Yeah, that's really true. Because I think, you know, in my 20s, I was also having irregular menses, and I went to a specialist because we happened to be visiting in Sri Lanka at that time. And, the first question is, are you married? And I was with my mom who took me that day, but I was in my 20s. I wasn't married, but, it was just because we wanted to find out, what is the issue and, is it PCOS,
Mhm.
and things like that, and, but yeah, to go to the reproductive specialist, endocrinologist there, if you weren't married, it was kind of like, oh, why are you here? It's because, it, well, you still need to find out what's happening and what's going on. But culturally, of course, that was many, many years ago. So I think things are changing in that regard, but still, it makes you feel shameful. And I
It
think
does.
that's why a lot of people hide their pain or their suffering. And as talk about, and they hide their health problems because based on whatever reasoning, they don't want to be shamed for it. Right. And a lot of people have that apathy towards, whether or not they want to care enough to do something for another person. And so it's really, really important that we are, talking about this and, trying to get that education out. And I love that you are doing this work. And I know we could go on and on. I have like so much more that I'd love to talk to you about, but I know it's like so long already. Maybe we need to do like a part two just
You
before
can
your
say a
book
part
comes out
2.
again.
Yes, it comes out in July,
Yeah.
and we can talk more about, like, Athena, the Athena and
Yeah.
Medusa legend, because this isn't
Right.
new. It's we're in the
Hmm.
21st century, and we're facing similar issues that have occurred for thousands of
Yes.
years, and we're in the United States, we're in a first world country, and women are
Hmm.
struggling, and I've had interviews in Australia and Europe, and even they've encountered similar issues. But can you
Hmm.
imagine third world countries and what women are going through?
Hmm. Yeah. Yeah. That's why, it depends on the country where you are. And I know I have a lot of friends who work in nonprofits and NGOs and work in, health organizations around the world that they're trying to get those research done, those community efforts in rural areas across the world, and I just hope that, people don't turn a blind eye to the work that is occurring globally and that is meaningful work globally, that we don't be apathetic to our humans connection around the world,
Absolutely. And rural health in the United States is another topic I'm passionate about. And you're in Oklahoma, I'm
Hmm.
in Missouri. And
Yeah.
so our states are quite
Hmm.
comparable.
Yes.
But like
Hmm.
32% of Missouri lacks labor and delivery units. And that is
Hmm.
terrifying for our rural women.
Yeah. Yeah, I've actually been reading a lot about how OB-GYNs are leaving rural areas in certain states just because it's become harder for them to practice. They're more concerned about liability and new, legislations. And, that's causing a huge disparity for women, for prenatal care, maternal care, postpartum care. And, that'll increase risk of maternal mortality, infant mortality.
Mortality.
And so, I don't know, there's a lot of things I hope that we can turn around, but can you leave us with some encouraging words? What have you learned that maybe is hopeful for tomorrow for women today?
It looks grim. It does. And we've touched on a handful of, maternal mortality
Yeah.
rates on the rise in the United States. Infant mortality rate
Hmm.
is high in certain
Hmm.
states, Missouri included. Physicians are
Hmm.
burnout because they're fighting with the
Hmm.
system. Patients are fed up because the provider, and patients are also fed up with insurance companies. But I've
Yeah.
been working on this book for 6 years, and we
Hmm.
have a lot more in common than we don't. We have similar stories, similar
Hmm.
backgrounds. And I've been doing interviews literally across the world over the last several weeks: Australia, England, Spain, South Africa, and even across the country: Boston, New York, Chicago, Detroit. And
Hmm.
there are so many women and phenomenal individuals who are working for the exact same cause that you and I are working on. It's not just, it is global is what I'm recognizing. And that gives me so much hope of this is a global movement. We are recognizing women. In this gentleman in England, his entire practice is focusing on the postpartum care. His whole focus is taking.
Yeah. And that's so hopeful to know that there are people around the world who are realizing this and stepping up. And I hope that we can all get back to the human part in so many different ways, in our workplaces, in our relationships, and just in every aspects of our lives. Remember that we're all in this together. And thank you so much for joining today, Kayla. I really appreciated this conversation and so glad to have met you. I think there's like a whole nother section in your book that we didn't even get to touch on. But thank you again. Thank you so much. And thank you all for joining us today for this conversation with Kayla Branstetter. I think one of the biggest takeaways from this episode is the reminder that suffering was never meant to be a performance of strength. Women do not have to earn compassion by staying silent, and pain does not become more holy, valuable, or valid because it's endured quietly. Kayla's work reminds us how powerfully it is when women tell the truth about their experiences, about grief, infertility, miscarriage, reproductive trauma, judgment, shame, and the moments when they feel dismissed or unseen. Storytelling has the power to heal, to advocate, and to create change in both healthcare systems and culture. Her upcoming book, Don't Be an Athena, releases July 20th, and I know this message is going to resonate with so many women who are tired of carrying pain silently while trying to appear endlessly resilient. If this episode encouraged you, validated you, or made you think differently, please share it with a friend, leave a review, and subscribe to the podcast. Those small actions help these conversations reach the women who need it the most. As always, thank you so much for being here and for being part of this community, where we talk honestly about medicine, motherhood, and missions, identity, purpose, and what it means to live fully human. We'll see you next time. Keep sparking hope. Thank you for joining us in this episode of Medicine, Motherhood, and Missions. We hope you found inspiration, insight, and a sense of connection in the stories we shared today. If you enjoyed today's episode, be sure to subscribe and leave us a review. Your feedback helps us reach more listeners like you. Follow us on Instagram for updates, free downloads, and to join a community of like-minded individuals passionate about making a difference through medicine, motherhood, and mission work. Remember, you're not alone in this journey. Until next time, keep sparking hope, keep healing, keep nurturing, and keep making a difference. This is Johanna signing off from Medicine, Motherhood, and Missions. The medical opinions expressed on this podcast are for informational purposes only and should not be considered as medical advice. Always consult a licensed healthcare provider for personal medical concerns or questions. The views expressed by guests are their own and do not necessarily reflect those of the podcast host.